rounds are courtesy of GI. I'd like to thank Alain Biton for inviting Dr. Yidan Lou to present to us. And Dr. Biton will be presenting our speaker today. So Alain, the floor is yours.
Okay, well, thank you, Nadia. So welcome everybody to GI Round. So it's really my pleasure to introduce to you Dr. Yidan Lou, who joined our division last year, and she brings in an expertise in nutrition and parenteral nutrition. So Yidan trained at McGill, did a residency in internal medicine and GI here, and subsequently did some training also at the SHUM in nutrition. She has a master's of epidemiology relating to nutrition. And she was actually also chief of gastroenterology at Notre Dame Hospital prior to joining us. So it's with great pleasure that I introduce you Yidan, who will speak to us today on intestinal failure and home parenteral nutrition. So Yidan, welcome, and we look forward to your talk.
Perfect. So thank you so much, Dr. Biton and Dr. Giannetti and the Department of Medicine for giving me the opportunity today to present on intestinal failure and home parenteral nutrition. I have no conflict of interest to disclose. So here are a few of the objectives that we will be touching upon today. So describe the presentation and etiologies of intestinal failure, to review the role of home parenteral nutrition for patients with chronic intestinal failure, and to review intestinal rehabilitation strategies, which include dietary therapy and pharmacotherapy for the treatment of short bowel syndrome. So the idea of creating an artificial nutrition system for patients who cannot tolerate oral intake has existed for centuries. The first documented case of IV nutrition came with the invention of the IV when Dr. Sir Christopher Wren infused wine, ale, and opiates in a dog. The first real case of parenteral nutrition is attributed to Dr. Dudrick, a surgeon at the University of Pennsylvania, who fed puppies with intravenous solution composed of glucose, fibrin, vitamins, and minerals, and was able to show a normal growth compared to orally fed puppies. Soon after, the real case of parenteral nutrition in a human subject was done also by Dr. Dudrick when he saved actually a young girl, newborn with intestinal atresia, and gave her parenteral nutrition for several months. Soon after, he described long-term parenteral nutrition, published 30 patients with chronic intestinal failure whom he managed to keep a normal growth and normal nutrients with an intravenous solution of dextrose, fibrin, electrolytes, trace minerals, and vitamins. Of course, when we talk about parenteral nutrition, we have to mention Dr. Gigi Boy, who's a gastroenterologist in Canada at the University of Toronto. He is really considered one of the pioneers of parenteral nutrition. In the 1970s, Dr. Gigi Boy created this artificial gut that we can see here, which delivered complete nutrition. So he had lipids, protein, and dextrose with this set up with compressed air that gave cyclic parenteral nutrition to patients. He also invented a central line access for these patients because back in the day, central lines like Broviac did not exist. So Dr. Gigi Boy is responsible for actually the earliest cohorts of home parenteral nutrition patients. 50 years later, parenteral nutrition is now a well-established therapy for intestinal failure. We estimate that about 25,000 patients in the United States currently receive home parenteral nutrition. Major advances have led to modern-day parenteral nutrition. They include, but are not limited to, a proper central venous access that is permanent and is able to deliver nutrients in the central line because of the high osmolarity of parenteral nutrition, portable pumps, and pharmacy compounding, high-quality compounding of parenteral nutrition with specific electrolytes that are usually adapted to each patient. So parenteral nutrition is actually a mix of macronutrients that are amino acids, dextrose, and lipids. So there are several types of lipids, and the current lipid we use is actually a combination of soy, medium chain triglyceride, olive, and fish oil. The additives that we put in parenteral nutrition include electrolytes, so we adjust it according to the patient's requirements, vitamins, and also trace iron. Parenteral nutrition now is considered a life-sustaining therapy for patients with intestinal failure that we define as a reduction in gut function below the minimum necessary for the absorption of macronutrients and or electrolytes such that we need intravenous supplementation to maintain health or growth. Parenteral nutrition is possible with home TPN in a way that patients with chronic intestinal failure are able to go home and receive parenteral nutrition in the home setting. The prevalence of home parenteral nutrition varies between 3 to 66 patients per million, and in Quebec, the number lies around 13 per million population. So on the home TPN program, our patients learn to administer their own parenteral nutrition. The image below is an example of a setup that the patient might have in order to sterilize their central line, add multivitamin, connect and disconnect their central line. It's a process that takes anywhere between 30 minutes to an hour every time the patient is on TPN. They also have portable pumps so that they can be mobile, and usually have a little backpack where they can move around with their TPN infusing. When most people think about parenteral nutrition, we have in mind sick patients in the ICU or on the ward who have an IV pole with a white bag or yellow bag attached to it. However, in real life, parenteral nutrition actually provides freedom to these patients who are able to resume work, go back to school, and carry on their daily activity. Our oldest patient in our program, who's been on the program for 28 years, is actually a very functional man. He climbs in the summer Mont Tremblant every day, so healthier than me and many of us. The home parenteral clinic at McGill is a multidisciplinary clinic. We have nurses, nutritionists, a pharmacist, and a physician. So the big aim of the clinic is really patient focused. Here, we really put the emphasis on the patient to give them autonomy to self-monitor for complications, for dehydration, and really to troubleshoot problems with their pumps. The clinic was established in 1992 by Dr. Shisgao, and soon after was taken over by Dr. Marlis, whom most of you know by now. Dr. Marlis really established the clinic and worked with it for 30 years. Dr. Marlis retired from his clinical duties this year after serving the clinics for an entire 30 years. So congratulations, Dr. Marlis, for his retirement. We are very, very fortunate to have a great team here in parenteral nutrition. Our nurses, Jean Amuan, Grace Wang, Caroline Prien, our nutritionist, and Suzanne Fournier, our pharmacist, have been just great with the patients. In the province of Quebec, we have 3 home parenteral nutrition programs in the adult setting. So with the CHUM and the CHU de Laval, we're the 3rd center. Our center here also covers for patients outside of Montreal and the whole use of McGill. One of the reasons why we only have 3 centers in the province is that intestinal failure is an exceedingly rare condition. It's one of the most rare organ failures that's documented. As a reflection of this, Here we can see the number of PubMed publications across different organ failures, and intestinal failure really is one with the lowest amount of publications. It is estimated to have a prevalence of 1 to 2 per 10,000 population, and an incidence of 1 to 2 per million. Intestinal failure can be classified into 3 types. So the type 1 intestinal failure will be the acute, short-term, self-limited condition. For instance, somebody that has an operation and the post-op period cannot tolerate anything, and then gets better after the ileus resolves. So this is typically the surgical patient. Type 2 intestinal failure is a prolonged condition, metabolically unstable, that lasts over weeks to months. So these patients refer to patients, complex patients in the ICU that have been there for weeks. For instance, patients that have had intestinal sepsis, complication, leaks. So these patients are unstable and they require TPN for a little bit longer period. Finally, the type 3 intestinal failure are the ones that we usually follow in our clinic. They're chronically dependent on parenteral nutrition, but they're metabolically stable. For instance, that could be a scleroderma patient who has progressive disease and has been needing TPN, but otherwise is stable. Intestinal failure can also be classified into different etiologies. So we have 5 main etiologies causing intestinal failure. So short bowel syndrome, intestinal fistula, intestinal dysmotility, mechanical obstruction, and extensive mucosal disease. Short bowel syndrome is defined as having a small bowel of less than 200 centimeters with evidence of inadequate absorption. That is mostly resulting from extensive bowel resection. So we would see this in Crohn's disease patients and somebody with mesenteric infarct and infarct of their whole small bowel, or surgical complications. More rarely, congenital causes such as intestinal atresia can also lead to short bowel syndrome. We have 3 types of anatomy that we tend to see in short bowel syndrome. So an angioduostomy, a jejunal colonic anastomosis when patients have at least 50% of their colon, and the iliocolonic anastomosis where patients have a bit of ileum left along with their colon. Intestinal fistula refers to an intracutaneous fistula that usually bypasses the digestive tract. So this can be seen in inflammatory diseases, again, Crohn's disease, but can also be seen in acute pancreatitis, complicated radiation enteritis, and most commonly postoperatively from iatrogenic causes. Intestinal dysmotility is more rare, but refers to feeding intolerance, but due to non-mechanical intestinal obstruction. So patients would present with intolerance to feed, nausea, vomiting, pain after eating from a slowed down, decreased motility of their GI system. It could be primary or secondary. Primary are neuropathic or myogenic causes. Secondary causes are probably the patients that we tend to see a little bit more, the collagen vascular disease, so scleroderma patients that have progressive disease, gastroparesis, Ehlers-Danlos that we tend to see a little bit more nowadays that often present with intolerance to feed, gastroparesis. Mechanical obstruction is fairly rare. It could be thought of intraluminal tumors, extrinsic bowel lesions such as strictures or stenosis, and extrinsic lesions being carcinomatosis or desmoid tumors. Finally, extensive small bowel disease refers to having insufficient absorptive capacity or losing nutrients from the mucosal surface. This includes variety of conditions, but most commonly we see radiation enteritis, intestinal lymphangiectasia, and autoimmune enteropathy, although there are very rare diagnoses. So when we are referred a patient to our home TPN clinic, we usually see two types of presentation. The first type is probably the outpatient who has had progressive malnutrition. They're unable to take oral feedings. They present with malnutrition. They have weight loss. They might have dehydration, electrolyte imbalance. So that potentially could be a scleroderma patient who had been doing well on maybe PEG feeds, but progressively are not able to tolerate their feeds and are losing weight and are actually sent to our clinics. The other category of patients that we tend to see are the inpatients who have been hospitalized for an acute issue, such as a volvulus mesenteric ischemia. They end up on TPN in the hospital and are unable to wean off TPN. When we see them, we do a full nutrition assessment. We also look for underlying cause of their intestinal failure, but our assessment also focuses on seeing whether the patient can be a good candidate for parenteral nutrition. So we assess if they have the cognitive and the physical ability to carry on in a safe manner parenteral nutrition and access their central line. Short bowel syndrome is really accounts for the majority of causes of chronic intestinal failure. That's followed by dysmotility and fistula. When we look at each diagnosis, we see that the top three diagnoses that account for over 50% of our patients are patients with Crohn's disease, mesenteric ischemia, and patients with surgical complications. Over time, we have noticed a slight change in our demographic of our patients. So there seems to be an increase in patients who have had surgical complications, perhaps because more patients have increased comorbidities or getting more complex surgeries or having just sicker patients. Fortunately, we are seeing less and less Crohn's disease, probably because we have such good therapies in IBD and Crohn's disease. One of the other categories that we seem to have seen a little bit more is complications from bariatric surgery. So young, usually females, presenting and ending up on home TPN secondary to complicated bariatric surgery. It's nice to see that many patients are actually able to wean off parenteral nutrition. So at 5 years, we estimate that about 36% of patients will be able to wean off TPN. The number can be even higher in pediatric population specifically. So the weaning process usually occurs within the first 2 years, but is also documented up to 5 years. And when we look at this graph for parenteral nutrition dependence, we see that this trend continues even at 15 years. The underlying etiology of intestinal failure will be the one that influences the most the need for parenteral nutrition, so parenteral nutrition dependency. It is lower in some surgical complications, such as fistulas, because probably we have a way to treat it surgically and to reverse it. Parenteral nutrition dependence seems to be higher in other causes, such as chronic intestinal pseudo-obstruction, which we don't unfortunately have good treatments at the moment. The reason why many patients are able to wean off TPN is because of intestinal adaptation. So intestinal adaptation refers to the structural and functional changes that occurs after extensive small bowel resection. So this occurs in patients with short bowel. So after resection, the gut adapts itself to increase fluid and nutrient absorption. On a microscopic level, we see that the crypt depth increases, the villus height increases, the bowel actually lengthens and becomes thicker with an increased transit time to allow better absorption. So the residual small bowel anatomy is highly important for us in order to predict who will need TPN. So we need to know the residual bowel length, and that's different from the quantity the surgeon have resected, because we know that small bowel, the normal bowel length varies quite a bit. It varies between 350 up to over 1,000 centimeters, with the average being anywhere between 600 to 700 centimeters. We also want to know the anatomy. So is there an anastomosis? Is there a stoma? Is there the ileocecal valve present? So when we look at numbers, again, the three kind of categories, three anatomical categories that we have in short bowel syndrome, and jejunostomy will likely require parenteral nutrition if they have less than 100 centimeters of small bowel that is left in place. When you have a little bit of colon, this number goes down to 65 centimeters. And the best case scenario is when patients have a little bit of the ileum left and the majority of their colon, and surprisingly, the number can go down to 30 centimeters. So somebody with only 40 centimeters small bowel, if they have their ileum and their colon in place, may be able to be off TPN. Missing in this landmark study demonstrated that residual small bowel length, regardless of anatomy, is a predictor of parenteral nutrition dependence. So if you're somewhere have more than 100 to 150 centimeters, it's a strong predictor that perhaps you will not need parenteral nutrition. So when we analyze the anatomy in greater detail, we see that the jejunum, the ileum, and the colon all have very different potential for adaptation and for absorption. The jejunum is where we absorb most of our nutrients in the normal setting. However, it is very, very leaky. So it's permeable to water and it's unable to absorb across the gradient. The ileum, however, is much better at absorbing across gradient. It also features enteral hormones that will create this ileal brake to slow down transit and increase absorption. Ileum has a greater potential compared to the jejunum for adaptation. The colon in the normal setting doesn't do much in terms of absorption, but when we have a patient with short bowel syndrome, the residual colon is very important. In fact, it can produce up to 1,000 calories in patients solely by fermenting complex carbohydrates into short-chain fatty acids in the colon. Additionally, having the colon will stimulate colon small bowel hyperplasia. It overall acts as a reservoir to slow the transit and allow fluid and electrolyte reabsorption. Colon preservation will decrease the need for parenteral nutrition. So when we have a colon in place, functionally, it really translates into decreased fluid requirements and decreased parenteral nutrition requirements. It's estimated that having 50% of the colon approximately equals to having another 50 centimeters of small bowel. In this study by Nightingale, he showed that there's a much greater IV fluid, IV nutrition need in patients with jejunostomy versus patients with a jejunal colonic anastomosis. And that threshold, again, same numbers, seems to be around 100 centimeters, under which patients will likely need parenteral support. The 5-year survival of parenteral nutrition ranges between 58 to 83%. Newer observational data put that number somewhere in between at 66%. And shows that at 10 years, about 55% of patients will be alive. The underlying disease is really the major driver of mortality in parenteral nutrition. It's lower in Crohn's disease and higher in certain conditions like radiation and enteritis. Other factors influencing and associated with increased mortality or increasing age, very short residual small bowel, so the ultra short guts, and having an enterostomy. It's worth noting that really, despite that, only 15% of deaths are directly related to a complication of parenteral nutrition, and that the main cause of death is really the primary disease. So our patients on the home parenteral nutrition program are unfortunately at risk for several complications. Catheter-related complications, namely catheter-related bloodstream infection, which is the most common serious complication in our patients. They can also have catheter thrombosis, loss of venous access. Parenteral nutrition-associated liver disease is a multifactorial condition that's caused by the types of lipid we use, the calories, maybe some deficiencies, and chronic inflammation, enterotoxin that somehow creates a range of liver condition ranging from just cholestasis, steatosis, to cirrhosis and liver failure. So fortunately, our adult population, the steatohepatitis rarely progresses into liver failure, which is a little bit different from the pediatric population, which once they have hepatitis and liver damage, they rapidly go into liver failure. Metabolic bone disease is another very frequent condition that we see in our population. A great majority will have osteoporosis, likely due to malabsorption and perhaps also medication like steroid use in patients with Crohn's disease that we have. Finally, chronic kidney disease, we also see often perhaps related to dehydration, but also kidney stones from malabsorption. The management of chronic intestinal failure will really depend on the underlying etiology, because there's the underlying etiologies are just very, very different. In our clinic, we aim to reduce PN-related complications. So we review things such as lipid infusion rates, glucose infusion rates, to make sure we're not overfeeding this patient to avoid liver complication. We also changed the lipids. From a few years ago, we were using a soy-based lipid. Now we're moving towards reducing that and going more towards a fish oil-based lipids, which has shown to improve outcomes in PN-associated liver disease. So short bowel syndrome has some specific diet and pharmacological therapy. So when it comes to diet management, it is really a fundamental part of managing short bowel syndrome, because that will have an impact on their parenteral nutrition requirements and their absorption. A very common misconception among certain clinicians and even amongst our patients who have been on this program for years is that you need to drink more when you are thirsty. So what happens is that patients are dehydrated, they feel thirst, they increase their water intake, and that leads to intestinal losses. So the more you drink, the more you lose, in fact. So we have to teach them and teach patients to really not increase their fluid intake and to limit their fluid intake. What happens if they drink water? They will have their sodium dragged out, so it will lead to a net loss of fluid and dehydration. We usually tell our short bowel patients to fluid restrict for about 1.2 to 1.5 liters per day. We encourage the use of oral rehydration solutions, because that allows patients to use the glucose sodium co-transporter and increase absorption. We tell them to avoid hypertonic fluids such as juices because this will create an osmotic load and worsen diarrhea, and also to limit hypotonic fluids such as water because it will drag sodium out. We encourage a high salt diet and even add salt tabs. When it comes to oral and PO intake, our patients, contrary to what people may think, is that they eat. They can eat a normal diet. They can eat 2,000, 3,000 calories per day. However, they don't absorb their entire calorie intake, and the absorption can vary between one patient to another. One thing we encourage is hyperphagia. So the more they eat, the more they might be able to absorb. So that percentage is still very important. When patients have colon incontinuity, we favor complex carbohydrates, so really use that colon to ferment into short-chain fatty acids and provide additional calories. For the pharmacological management of short bowel syndrome, we have a few therapies. First one being the proton pump inhibitor, which has been shown to decrease the fecal weight. This is especially useful in the first few months after surgery to really decrease the output. Antidiarrheal drugs are something that you use regularly at doses that's probably more than we usually see in clinical practice. We favor loperamide because it does not cross the blood-brain barrier, so limited side effects. And we use huge doses up to 16 milligrams titrated up QID about half an hour before eating to really slow down the bowel and allow proper absorption. Other medications we use are Lomotil and codeine in combination when loperamide fails. Octreotide is often mentioned. However, it is not routinely recommended as a first-line treatment for short bowel syndrome because we think that it may reduce intestinal adaptation, probably by reducing biliary pancreatic secretion, which is useful to stimulate adaptation. And then finally, the new kid on the block is the GLP-2 analog. So GLP-2 is actually a hormone that's secreted by our own body, the enteroendocrine cells and the terminal ileum. GLP-2 promotes enterocyte growth, it promotes fluid and nutrient absorption. Its effect is shown by increased villus height and crypt depth. The GLP-2 analog, which is called teduglutide or Revestive, was actually discovered at the University of Toronto by Dr. Drucker. He was working on the proglucagon gene for quite a while when he transcribed a glucagon-derived peptide and noticed that it caused marked enlargement of small and large bowel. That turned out to be GLP-2. However, it was very rapidly degraded, so he had to modify one amino acid to create teduglutide, which we know today as a stable molecule that is used as in subcutaneous injection daily. Here's the first study for teduglutide, which compared it to placebo in patients on chronic renal failure over 24 weeks. The primary outcome that was looked at was a reduction of at least 20% in parenteral nutrition volumes. So at 24 weeks, 46% of patients on teduglutide reached that endpoint versus 6%. In the extension study, over 52 weeks, we saw that if you continue teduglutide longer, there will be more people who will respond. So at 52 weeks, you have 68% of patients that reach the endpoint of having a 20% decrease in their parenteral needs versus 46, which we saw previously at 24 weeks. Response and weaning on teduglutide. So this meta-analysis looked at response rate, so those who will have a decrease in at least 20% of their needs, and weaning rate, meaning they will be off parenteral nutrition completely. And we see that response rates and weaning rates both increase over time, and the weaning rate can go around 20% at 2 years. Surprisingly, the residual small bowel length is not a predictor for response. We do know that patients with jejunostomies, patients with higher baseline volume will have proportionally a higher decrease. But bowel length was not associated to be a predictor of either response or weaning. When they looked at response, the only factor that seemed to influence is baseline oral intake. So somebody that had higher oral intake, hyperphagia, probably is able to wean off TPN on teduglutide to respond to the teduglutide. The same factor, high baseline oral intake, was also shown to be associated with weaning. In addition to that, patients who were weaned off TPN had less likely to have a chance to have an ileostomy. So those patients did not wean as much. And patients who were able to wean had a lower baseline volume, which makes sense. So if you have lower needs and you were only on, for instance, 3 to 4 days a week of parenteral nutrition, probably they have a better chance of coming off completely versus somebody that's dependent 7 days a week on parenteral nutrition. The cost of teduglutide is, however, the limiting step. It's estimated to cost about $400,000 per year in the US. A cost-effectiveness studies show that this cost needs to be reduced by 65% in order to reach the willingness to pay threshold. Finally, short bowel syndrome specific therapy, we discussed a little bit intestinal rehabilitation. There's that spontaneous intestinal adaptation that's seen post-bowel resection, but surgical reconstruction can also be helpful in our intestinal rehabilitation. When we talk about surgery, we talk about stoma reversal, so re-establishing a continuity with the colon, fistula closure. Surgeries like reverse intestinal segments, a colon transposition to slow the transit, or intestinal lengthening procedures, as you see below, are either not commonly used or more seen in the pediatric population. But having reconstructive surgery is associated with a higher nutritional autonomy. Finally, a quick word on intestinal transplantation, which remains a treatment for intestinal failure. Intestinal transplantation could be an isolated intestinal transplantation, a liver and small bowel transplantation, or an en bloc multivisceral transplant that would include the stomach, the duodenum, or the pancreas. Outcomes for intestinal transplantation have quite improved over time. It's estimated that a 1-year graft survival is about 93% in, of course, highly specialized expert centers, whereas that number used to be around 69% in 2009. Currently, we estimate that a 1-year survival overall is 83% and 5-year survival is 58%. Nonetheless, this is a highly complex procedure. Patients are at risk to have complications. They have high risk of acute rejection and non-insignificant rate of PTO. In 2020, the indications for intestinal transplantation were revised to reflect a little bit more of a modern parenteral nutrition. So the main reason why patients would need an intestinal transplantation is for progressive intestinal failure associated liver disease. So when patients also have liver failure translated into high bilirubinemia or reduced synthetic function, portal hypertension. So this this is a fairly common cause, and these patients would usually get a liver and small bowel combined transplant. Loss of venous access is the other indication for intestinal transplantation, because these patients are fed through their veins. So if they have no more venous access, unfortunately, we're unable to give them parenteral nutrition. The last category is really a case-by-case basis of a specific setting, such as a patient with desmoid tumor or a patient with acute hepatic failure post-infarct that would require parenteral intestinal transplantation. While the prognosis has been improved over the years, we see that there's a decrease in intestinal transplantation worldwide. So it peaks in around 2007, 2008, and has been declining, perhaps maybe because we're doing such a great job with maintaining patients on home parenteral nutrition. So in conclusion, chronic intestinal failure includes various etiologies, such as short bowel syndrome, intestinal fistula, dysmotility, mechanical obstruction, and small bowel disease. Home parenteral nutrition is an effective and life-sustaining therapy for patients with chronic intestinal failure, and its major mortality is really the underlying disease than the treatment itself. I want you to remember that dietary approaches are really the first line. So if you see a patient on the floor with a high output, jejunostomy, we need to really fluid restrict them rather than tell them to drink more. Pharmacotherapy are useful in short bowel syndrome. They include PPI, antidiarrheal, and GLP-2 agonists. And finally, intestinal transplantation, although we rarely need it, is highly important for patients that fail parenteral nutrition.
Thank you so much. Thank you. Really very interesting presentation, and thank you for this thorough overview. Congratulations on all the work that's being done in this institution. I see Errol Marlis is there, who's been, a pioneer and a leader in this field for many years. So I'd like to open the floor for questions. Just before, I'd like to remind everyone that in about 6-7 minutes, we will be showing a pre-recorded video from Dr. Martin Laliberté about the elections coming on to the CMQ. So please stay with us for this. The floor is open for questions, and I ask you to please enter your questions in the chat if you have any questions for Dr. Liu. While I'm waiting for the questions to come in, question for you, in terms of what we do in this institution in terms of advanced therapies, I don't think we have access to GLP-2s, any of the surgical or certainly the transplant. We're not doing any of that in this institution, are we?
No, so we do have access to GLP-2. We don't have any patients on it yet, but it is available, and it is actually reimbursed by the RAMQ. So we have a few patients in mind that we will likely need to start therapy. They're a little bit reluctant because when you start it, immediately you have an effect in increasing your bowel absorption. So we need to proportionally decrease their fluid, and as they increase their absorption. So that's even problematic with medication. So they're on beta blockers for their heart. They may actually need lower dosages for blood pressure medication too. So for patients who have been stable under the care of Dr. Marlis, they really want to hold on to their stability. But there's a few that we're looking at. Intestinal transplantation, the closest center we have is Toronto. So we've had 1 or 2 patients sent there, and one that probably a lot of people at the Glen know, a young woman had a multi-visceral transplant in Miami a few years back, and is doing fantastic now off TPN completely. So we do have those options, even though they're not available right here at Amigo.
Being a multi-organ transplant center, have we ever considered having intestinal transplant here?
I think it was mentioned. It's just so rare, right? the number of transplant worldwide is so rare. So you really need to have enough volume. So I don't know that at this stage we have enough volume. And the SHIM also we're considering this, but didn't go forward because of volume, and probably it's better left to really centralize it in Toronto at this stage, unless we start to have more and more patients requiring intestinal transplantation.
Okay, we have a question from Dr. Zanelli. Once the intestinal hypertrophy has developed, can the GLP-2 be stopped, and will eating maintain the trophism and ongoing gut function?
No, unfortunately. So whenever their gut grows, once they stop it, they go back to their baseline. So it needs to be a daily injection. There are some studies looking at a longer acting GLP-2, but for now it's really daily injections for them. And interestingly, you really see the stoma grow, and some patients actually notice a change in the size of their stoma. And they may, as a result, have a bit of abdominal pain as the main kind of the main complication for GLP-2.
Okay, fantastic. We have a question from Dr. Rosenblatt. Have we been doing any studies on the change in the microbiome of these patients?
We haven't, but there are several studies that are published showing that short bowel patients have a different microbiome. So that's been looked at, and it is different.
Okay, thank you very much. I don't see any other questions right now. Dr. Marlis, I see you there. Did you want to say a few words? You have your camera on.
Yes, I'd like to add that the MUHC is starting a whole new era with the arrival of Dr. Liu, because she's bringing, as you've seen, a tremendously broad knowledge base and experience, and I think our patients are going to be benefiting from it a whole lot more than in the previous 30 years.
Thank you very much, Dr. Marlis, and we thank you very much for your many, many years of dedication to this particular service at the MUHC. Thank you very much, Dr. Yidan Liu, for joining us today, and for everyone for participating. We will end this portion of the grand rounds, and I'm going to ask you to stay on. Emily, if you can just show the pre-recorded video from